Goodness.
I'm gonna hop over to
The
Facebook.
dramatics and
It is.
theatrics.
It's very
We love
dun
it.
dun dun. No turning back now. I just will hop over to confirm that it is streaming before we start.
Perfect.
Takes about 30 seconds. But the good news, what I love about the show is there's always people waiting at the door for it to
Oh,
open.
nice.
And there we go. We are indeed live. Boom. Okie doke. We've got people in the room. Let's not keep them waiting any longer. Let's start the show. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation and LACNets program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this episode and every episode. I'm a filmmaker and a writer by trade, but I've been working with CCF for 12 years now to create all kinds of video content. We do patient-centric documentaries. We do dense treatment-based videos, live video series like the ones you'll watch today, but they all have the same mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we're here to do. Now, if you're new to this journey or new to the show, I want to say, first of all, welcome. And the value that you're going to receive today, in my very strong opinion, is twofold. One, the information and hopefully answers to some of your questions that you'll get from our guest, whom I will announce in a moment. And two, the shared experiences and shared stories within the community itself. The community we've cultivated here at Luncheon with the Experts and the overall net community, which is incredibly supportive, incredibly strong. I've never seen anything like it. And what I mean by that is you can see people in the comments saying hello and telling us where they're signing on from. I encourage you to do the same. Reach out to them, establish those connections with them, embrace the community. I promise you, it will embrace you back. It is very, very powerful. This is one of the many things that we have been doing with our partnership with LACNets, which has our guest and I were briefly talking about before we started the show today. It's been a fruitful relationship so far. And another thing I wanted to call attention to from that relationship is the support line that you can find at lacnets.org/support line. We will try to add that into the comments along with any other references that we mentioned through today's episode. Now, before we get started, we always want to thank our sponsors, Ipsen Biopharmaceuticals, for their support of Luncheon with the Experts. Simply, we couldn't do the show without them, but we have this disclaimer from them. And it's a little wordy, but bear with me. The disclaimer is the opinions expressed by the guest presenters, as well as the questions asked by the audience at home, haven't been created or suggested ahead of time by the sponsors of Luncheon with the Experts. And CCF and LACNets don't necessarily endorse or promote any of the views, opinions, or information provided in today's presentation. Here's the takeaway. So audience members should not rely solely on the opinions or information expressed by the guest presenter and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, so that is really just saying we're going to give you some good general advice, hopefully answer some of your questions, but each case of this disease is unique. So take that advice and those answers back to your home team, which does know your specific case, and make the best plan and path forward for you. That's really what we want to hammer down there. Now, today, I'm excited to welcome back to the show. I've lost count how many times this guest has been on the show, Dr. Aman Chauhan, although he is dialing in this time for the first time from a new location. Not so new to him because it's been about a year now or so. But Dr. Chauhan, welcome back to the show. How are you today, my friend?
Thank you, Rain. Thanks, and good to see you again. I agree. I think I was thinking how many times we've done. Actually, one time you flew into Kentucky to do it in person,
That's
and
right.
since then the series has taken off and has helped tremendous number of people. So congratulations to you, LACNets, for the recent collaboration. I think they are awesome groups. A thumbs up to them. And of course, to the sponsors, without their help, we would not be able to continue this. Great. And I'm already seeing messages from a lot of familiar faces. Hello, everybody from Miami. I always like to hear where people are from, so please type in where you're logging in from. It's really cool to see the footprint that this series kind of has globally. Great to be here, right?
Love it. Love to hear that. So, for those that may not be familiar with your new role in Miami, tell us what you're doing there now that you've been there about a year, I believe.
Yes, yes. So has been a fantastic journey. A lot of you have know me, but for the unversed, I went to Kentucky. I was in New Orleans for during my residency in 4 years, and New Orleans has a beautiful neuroendocrine cancer program, as you know, the NOLA Nets, the real NOLA Nets now. And they trained me well, and they asked me to go and do fellowship in Kentucky, where I was very fortunate to get trained under Lowell Anthony, Ed Volin at University of Kentucky. So spent another 3 years studying neuroendocrine cancers there, and then had a beautiful opportunity to work with Dr. Anthony for a good 5 to 6 years after finishing my fellowship. But time was up to move to new areas. I got this lovely opportunity at University of Miami Sylvester Comprehensive Cancer Center to lead our neuroendocrine cancer program. I also co-direct our theranostics drug development program at Sylvester. When I moved here about a year back, I didn't realize that there was such an unmet need. We cater to several millions of population in South Florida and larger Caribbean. And it's the program in the first year took off, and we cater to over 400 new patients in just first 12 months. So I'm glad that I was able to come here, establish a neuroendocrine cancer program, and really fill that unmet need in our neck of the woods. So that's what I do. Do 2 days of clinic and rest research. That's what motivates me, trying to find new treatments, and hopefully a cure one of these days, both for low grade nets and high grade poorly differentiated neuroendocrine carcinomas.
Got it. Thank you so much. And folks, I see lots of people chiming in from Facebook as well as YouTube. Go ahead and start sending in your questions, a little bit of best practices that will help you. If you can ask them in smaller chunks, generic chunks, we don't know your specific case, that'll help us field the question in this format. If we need more information, Dr. Chauhan will ask for that. And if you're still in the call, you can add that for clarification later. But sometimes it's really hard with a really, really long paragraph to field those questions in this format. We're going to try our best to get to all of them. There's no limit to how many you can ask. So if you answer in little chunks, you can always ask follow-up questions. We'll try to get to as many as we can. And again, if we don't get to your question today, we are doing the show every 2 weeks this year. And of course, I urge you to reach out to lacnets.org/support line to help get some of those other follow-up questions answered. Go ahead and start sending them in, and we will get to them ASAP. Yeah, Dr. Chauhan, I had forgotten that I had come and done that first. This was kind of our prototype, if you will, that first year. So I guess that was 2019, because then we had to pivot pretty hard when COVID hit,
Right.
and not do the travel. And that's what created the remote version of the show, which has done quite well. After that, I think we did one every week for 2.5 years, maybe. We did a lot. So yeah, you helped us break down the walls. So
No,
yeah,
I bet you like the quality of life and not traveling so much. But it was sort of fun to meet people in person. And
yeah.
it has a different vibe and energy to it.
Totally. I totally agree with that. But so we're still trying to lean on the technology to help us. It definitely helped us reach a lot more people for sure. But yeah, we appreciate you helping out. Can you believe that was 5 years ago? So let's start as the questions are starting to come in. I know you established what you're doing there, leading the NET program at Miami. This will be a big question, and I know you've trained under some of the best. So this is a great opportunity for you to lead this program. What are you trying to focus on the most? Again, I know that's a super vague, super big question, but you've been given the opportunity to drive this forward, and I know there are many other players and people helping, of course. But if you could bring it down to kind of a central focus, is there a central focus that's kind of guiding you as you try to drive this ship?
Right. Great question, Rain. So I've been trying to also figure out a lot of things over past 8 years of my career. And one of the things that I realized is neuroendocrine cancers, it's a spectrum of disease, right? So there are not just one type, there are different subtypes of neuroendocrine cancers based on the grade. You can belong to either well-differentiated neuroendocrine tumor, we call NETs, NETs, and the other category is a poorly differentiated high-grade neuroendocrine carcinomas, NECs, very aggressive, very rapidly growing. So our techniques, tools, and urgency is very different. But this is a spectrum of the disorder. Also, neuroendocrine cancers are not limited to one organ system, right? This is not a GI cancer. This is not just a lung cancer. you can have neuroendocrine cancers almost anywhere. Recently, I saw 2 cases for middle ear neuroendocrine tumors, throat neuroendocrine tumors,
Hmm.
of course, gastric, GI, lung, pancreas are more commoner varieties, but you can also see neuroendocrine tumors in breast, ovaries, cervix. So, what during my career, I felt that there should be a grade agnostic and a site agnostic neuroendocrine cancer program. Many programs, I realize, cater to, okay, if you have GI, you go see a GI oncologist, or you have a lung primary, you see a thoracic oncologist. And in their respective domain, neuroendocrine cancer might be a super rare entity. But if you have a all site encompassing neuroendocrine cancer program, then you can really focus even on the rarest subset. For example, if I, for me, if you club all the neuroendocrine cancer from head to toe, it makes a quite large volume. So it makes it viable for our university, for our cancer center to invest in multiple research protocols and research resources, because we are not now seeing one odd case. We are seeing almost 20 cases a clinic day. So I think putting together a multidisciplinary neuroendocrine cancer program, which sees through the whole spectrum of neuroendocrine tumors, not just the GI, not just the lung or the common varieties, I think that was very eye opening for me, and that's what I'm striving for. So we are catering to gynecological neuroendocrine cancers. We are catering to head and neck neuroendocrine cancers,
Wow.
and I think that's the way to go forward for these type of cancers, which are, site agnostic. It can happen anywhere in the body. So that's one of the things we are trying to do here. The second thing we are trying to do is the any neuroendocrine cancers, unfortunately, have seen the least amount of progress in last 30 to 40 years. We've made tremendous progress when it comes to NETs, and you've seen it in front of my own eyes. 5 or 6 years back, we hardly had many treatments. Now we have several FDA approved treatments, and others are coming down the pipe, and a lot of really promising clinical trials happening for NETs. But when it comes to NECs, this is still a very aggressive disease. The median survival is a year to 2 year. The 5 year survival rates are under 10%. So a lot needs to be done. And that's what I realized. And a lot of my energies are also focusing on the high grade neuroendocrine cancer, where we're trying to develop new trials, new drugs, to preclinical work, and try to move the needle in that space. So a big chunk of my focus is on high grade neuroendocrine cancers. But of course, because of the bigger prevalence of NETs, we do see a lot of NETs in the clinic by default.
Got it. Thank you so much. That clears that right up. And yeah, I was just thinking about your whole career in that span of years. There's been so much activity in this space. Like, because I've been working tangentially with nets, like I said in the beginning, 10 to 12 years. So I've had the chance to see that from an outside perspective. And
Right.
it's been wild for the past 8 or 10 years. We got some questions coming in, so I don't want to delay any longer for those. Let's start taking some questions from the audience. We appreciate you all being here. By the way, everybody in attendance, if there are people not here that you don't see yet, sometimes they forget. Since we're doing bi-weekly, go ahead and tag them in the comments or share this video with them. Hit them up, let them know that we're here and the show is going on. First question comes from Dorothy. Dorothy says, does fatty liver disease, non-alcohol fatty liver disease, make it more difficult to see nets on a CT scan?
Great question. And, fatty liver is a very common entity. No matter where you're from, US, India. I know a lot of friends in India back home dealing with this because of our lifestyle, the dietary changes. We are seeing a lot of fatty liver. So it's basically fat deposition in the hepatocytes or the liver. And based on the degree of fatty liver, there could be different forms. Of course, the most severe form would be the fatty liver is cirrhosed, or like it's become scar. um, how it impacts us, very important to understand the background, health of the liver, because liver is by far the number one site where neuroendocrine tumor likes to go. So neuroendocrine tumors can metastasize to bones, lymph nodes, and several organs, but by far the liver is the most preferred site where neuroendocrine tumors like to go. So we really need to know how the liver is doing and be able to track our disease in liver really precisely to understand if the treatment's working or not. And sometimes if there is a background noise, is a underlying liver cirrhosis or fatty liver disease or something else happening with the liver, that can really impair our ability to visualize liver disease or burden liver well. Sometimes just the nature of disease or neuroendocrine tumor, the way the metastatic disease, it's very diffuse and large involvement of liver and about the true extent of the disease. So it can make it difficult, and that's where we use different modalities. For example, for some patients, an MRI of liver with a dye called EOVIST might be better suited and might give us the sharpest picture of the liver and the lesions in the liver and may be able to help us figure out how the disease is doing. In some patients, actually the majority of patients, just a CT scan with triple phase, is more than enough and gives us a very good information. Right? The advantage of CT scans are is a quick, unlike MRI where you have to be in the tube for a very long period of time. So you don't really have to do MRI on everybody unless there are special needs and it's very difficult to assess the disease in CT scan. Sometimes both these CTs or MRIs, what we call them cross-sectional anatomic imaging, right? So we're trying to get the actual measurements of the disease. Sometimes both of them are not very helpful because the way the cancer is in the liver is just diffuse involvement. The whole liver is studded with tumors, and there's really no distinct lesions that we can measure, right? So in those cases, sometimes the molecular imaging, like PET scans, the dotatate PET, helps us because it helps pick up the somatostatin receptor positive disease, and we can actually see distinct lesions better. So it's really no one size fit all approach. That's why we have to individualize. But yes, if you do have background of fatty liver, it might in certain cases make your disease a little bit more challenging to see. But if you are able to do a proper protocolized imaging, for example, if you're doing CT scan, make sure your CT scans are triple phase. I think you might not have those difficulties.
Got it. Thank you. And thanks for your question, Dorothy. From Diane, are there any treatments that may not be advisable for someone with a PNET, with a biventricular device? For example, histotripsy, embolizations. Also, thank you both for what you do. Yeah, you're welcome. So, are there any treatments that may not be advisable for someone with a PNET, with a biventricular device?
I'm not aware of any contraindication in terms of the neuroendocrine tumor therapies. You know, pancreatic neuroendocrine tumors probably have the most number of treatments available, which are considered on label. So FDA approved treatment. So you're talking about sandostatin, lenriotide. You're talking about Lutathera. You're talking about sunitinib, and now we have stellar data on cabozantinib, Afinitor. So we have a host of systemic treatment options when it comes to pancreatic neuroendocrine tumors. And to my knowledge, there is no absolute contraindication for any of these systemic treatment options with the biventricular devices. Now, regarding um, uh, what type of so the patient is asking about specific liver directed therapies like histotripsy, which is uh, ultrasound guided liver targeting versus liver directed therapies, embolizations. I do think histotripsy, by the way, is very new, relatively new as compared to been using it for past year and a half. So in that ballpark, so I don't fully understand the long term implications if somebody has had Whipple surgery before or some sort of other intervention. But to my knowledge, I don't think there is major contraindication. I think how the interventionist or IR doctor picks one modality versus others based on the lesion needs to be visible uh, to the ultrasound machine. If in areas of the liver, you can't really target all the areas. Similarly, for liver directed therapies, certain liver directed therapies are suited for certain locations in the liver, for example, Y90 versus bland embolization. Again, I would recommend that you consult with the surgeons and interventional radiologists to understand that would you be a good candidate for one liver directed therapy technique versus other. There is no absolute contraindication that I can think of,
Okay.
unlike Y90 versus bland embolization, where one cannot be done if you have Whipple's procedure.
Right. We do have a couple of other questions on histotripsy. Are you okay to field those? I know you've
Yeah,
kind of
sure. I mean,
kind of
again, this
addressed.
is this is a little bit outside my area of expertise. I can try to address
Yeah,
some of those for sure.
I think one of them you partially addressed, and I might just have you kind of lay down what you do know about. We get questions every week now, but it's the new thing, right? So a lot of people talk about it. The one question from Diane says, "Do you know if histotripsy could be done on uncinate process PNET?" So I don't know. We can start there, or we can just establish what you do know and what
Mhm.
histotripsy is, who might be best qualified for it, etc.
Correct. So, in my understanding of historypsy, is it is just another way to destroy tumor.
Hmm.
Um, of course, it's not as good as surgical resection, right? So just like how we do ablation, microwave ablation,
Hmm.
or histotripsy, or liver-directed therapy through embolization, it's there to debulk the disease, to kill the disease, lower the tumor burden, right? But it's not going to be as good as surgery. So, if the goal of the treatment is cure, if we are dealing with an early stage cancer, the cancer was incidentally caught early, it's just one spot in pancreas or some other organ, I will not advise them to go for these experimental therapies, rather go for the definitive treatment, which is surgery, and get the tumor out. So if the tumor is in uncinate process of the pancreas, and I presume that's the primary tumor, you would want to discuss with the surgeon that see is it a resectable candidate or not. Now, if we are dealing with metastatic disease that's not only in the pancreas but it's also in several other spots in the liver, so there's clearly no role for surgery in curative dissection. In those cases, we can then discuss the benefits or versus risk for debulking certain tumors. So in those kind of areas, I don't know what would be the urgency to ablate or debulk disease in the uncinate process unless it was causing some sort of obstruction. And if that was the case, usually the route we go by is putting some sort of stent. So again, it seems like the clinical scenario is not very clear to me at this point in time. If it's the early stage, I would not mess around with these newer. Want to do a competent surgeon see if it can be resected, because surgery is still the standard of care when it comes to curative resection. In metastatic setting, the typical role for histotripsy is it targeting liver lesions. And Rain, the reason why do we do debulking, or why do we target and reduce and kill some of these cancer cells? There are some neuroendocrine tumor patients which are called functional neuroendocrine tumor patients. So the tumors are secreting certain hormones, could be serotonin, could be other hormones, right? So if
Hmm.
you kill some of the tumor, it lowers those hormones and it improves the quality of life for the patient. So that's the advantage of targeting these lesions, right? And these are just different techniques. Could be surgical reduction, cytoreduction, could be embolization, could be histotripsy. So we don't know one's better than others, but what we do know from surgical papers that if you cytoreduce or debulk disease, patients tend to do better. And that makes sense because they tend to have lower of the, functional syndrome symptoms, right? In non-functional symptom patients, for example, they're not producing any hormone, and the two and it's not bothering them. There's no randomized prospective data that okay, you have to cytoreduce and it will do better. But in then in certain cases we still advocate for debulking, because uh, eventually why we get in trouble in neuroendocrine tumor patients is when we lose the liver real estate, right? The liver is a vital organ, and liver is very resilient and it can function very well up to a point. If 80% or more of the liver is involved with the tumor, and that's when we start seeing decompensation of liver and liver failure symptoms, right? So we are trying to prevent that. We are trying to minimize the liver burden, the tumor, to a point that liver has some breathing room, and that's why we are using these technologies. Histotripsy is very interesting because it's non-invasive, and
Mhm.
that's the only major advantage I see about histotripsy. You don't have to be cut open for this, right? But that doesn't mean that's the one short treatment and cure for all liver debulking, right? I still think that what surgeons would be able to do with surgical cytoreduction, because they can actually go in and resect as many smaller and bigger tumors, uh, will still continue to have its role. And liver directed therapies will have its role, because not every lobe of the liver can be used for histotripsy. There could be certain areas in the liver which the interventional radiologist cannot really see or visualize very well on the ultrasound. If you can't see it on the ultrasound, then there's no histotripsy, right? Because it's ultrasound guided. So I think these are different tools, and we need to tailor which tool is better suited for which patients, rather than saying this one technique is superior to everybody, right? But for this particular question regarding unsynate process, I'm skeptical. Why do we even need to do histotripsy there? What's the and again, of course, I don't have a lot of information about this patient specific scenario.
Right. 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 Thanks, Diana. Hopefully that helps. Let me know if you have any other questions. Next one comes from Catherine, and also someone else in the comments said, I have the same question. Catherine says, when one has carcinoid syndrome treated by lanreotide and experiences hypoglycemia multiple times a day, how do you think through the cause? Drug or tumor, and if tumor, insulinoma producing serotonin or carcinoid tumor producing insulin. Nothing is showing on the PET scan to date.
Oh wow. Um, so if somebody has hypoglycemia symptoms,
Hmm.
um, first step is to be able to, great job that you know what hypoglycemia symptoms looks like, feeling weak, giddy, dizzy, legs kind of crumbling at the knees, and then you take something sugary, you perk up, right back up, you feel energetic. So that should be your clue. Okay, you're having some of the hypoglycemia or lowering of sugar symptoms. It's not very common, but it can happen. Now, there are two reasons why it can happen. One is, as you mentioned, patient has insulinemia or hyperinsulinism. So certain neuroendocrine tumors like pancreatic nets. So it's a neuroendocrine tumor of pancreas, which is secreting insulin.
Hmm.
And if you have too much of insulin, of course, what does insulin does? Insulin will cause your sugars to go down. It helps absorb the sugar into the tissue. So your spike in insulin, your sugars will go down, right? So if a pancreatic neuroendocrine tumor is suspected, then it's an easy workup, and we check for insulin level, and certain peptides that are associated with insulin. So we do a full, endocrine workup to rule out an insulinoma. Okay, that's easy to do. Now, if insulinoma workup is normal, because insulinoma is pretty rare, then we have to entertain what could be causing lower sugars. So a couple of differential diagnoses that comes to my mind in our group of patients. Number one is diabetes. Diabetes is a very common endocrine disorder. A lot of patients might be diabetic, and certain medicines which are started by their primary care doctor or their endocrinologist for diabetes can actually into others end. From high sugars, you kind of really bottom down your sugars. Or if somebody recently started on a drug called glipizide, your body's just not able to handle it, and you just bottom out. So you really need to do a thorough review of the medicine. Hey, was there any change in your diabetes medicines lately? Are you using more of it? It's a possibility that you are on a certain set regimen of insulin or your diabetes medicine, but you end up losing a lot of weight as a part of your either cancer diagnosis or on purpose, and your sugar control is getting better, but your medicine, you're still taking the same high doses of diabetes medicine, so it's bottoming you out. So you really need to do a thorough review of what medicines and could other medicines be causing any hypoglycemia issues. um, the other differentials I look into it, especially with regards to neuroendocrine tumors. Are neuroendocrine cancer patients, some of them are at risk for malabsorption because they have short gut syndrome. They might not have part of their pancreas as a part of pancreatectomy surgeries, so they're so they're not digesting well. So if you're not digesting well, you're not absorbing enough of the sugar. So is the hypoglycemia symptoms is a part of rapid transition of whatever you're eating, it's not getting absorbed. You could have a ostomy bag. So you also have to figure out nutritional aspects to it, right? And last but not the least, our own medicine, like the listener alluded to, somatostatin analogs. Could that cause it? Again, many times I have noticed that it causes increase in your sugars. So I once in a while will check sugar levels and cholesterols and lipid panel, but rarely you can also sometimes see lowering of the sugars because these somatostatin analogs, they have a broader effect. They suppresses a lot of secretions of a lot of other hormones. So certain hormones have indirect way of increasing your sugar, so when they suppress those hormones, it can lower your sugar. So it can certainly be one of the differential diagnosis. How do we fix it? Of course, um, if we know the right diagnosis first. So you have to do this exercise, what's causing your hypoglycemia. So eventually, if you figure out this is coming from your injections, your monthly injections, then one of the things that you can do is alter the dose. So especially you have luxury to do that with standard because it comes in different formulations of the dose. So you can try to lower the dose, see if that fixes the problem. If this is still a significant problem, you can't fix it, then of course you might have to just stop the somatostatin analog and move to a different treatment option for your neuroendocrine tumor. So that's how I kind of go through in my mind the differential diagnosis for hypoglycemia. Of course, one more thing I'd like to mention, and that's why neuroendocrine cancer is considered a multidisciplinary
Hmm.
field. You really have to call in your friendly endocrinologist, right? You can't do it all by yourself. So they call you for cancer management, you call them for any hormonal management. So if hypoglycemia is happening and you feel that there is these interplay of either insulin levels or some other levels, I'll give you another example. For example, I once had a case of glucagonoma, and that's a complete opposite scenario of insulinoma, where high glucagon level causes patient to have tremendous high sugars. So again, you really need to have a good endocrinologist, a part of your neuroendocrine tumor team for these type of special situations.
Got it. Thank you, Catherine, and Kat as well. Next question from Grace over on YouTube. The newly released clinical trial had PRRT as a first line treatment in combination with octreotide, but the trial was on higher grade NETs. Is there an approach or a trial to test this on lower grade tumors?
Great question, Grace, and hats off. You keep up to date with the latest data. So, Grace is alluding to Netter 2, which was released this year at GI ASCO. Netter 2 studied Lutathera. You're familiar with that drug. It's a PRRT drug, which we use in neuroendocrine tumors. It's a radiopharmaceutical. We inject it, it latches onto the somatostatin receptors of the neuroendocrine tumor and kills the tumor. Available in US since 2017, 2018, after the Netter 1. So in Netter 2, what the investigators did, they wanted to study this Lutathera drug. Does it work well in higher grade or more aggressive neuroendocrine tumors? So they took all the patients who have well different neuroendocrine tumor, but grade Ki6 is more than 10%. So higher grade 2 and grade 3. Because this is a more aggressive disease, a relatively more aggressive disease, and we don't have a lot of good treatment options. So We know Lutathera is a very solid treatment option, so we wanted to test it out in that disease type. Um, to answer Grace's question, has this approach been tried on lower grade nets? Lower grade net is a very different disease. Okay. So I have no doubt in my mind that if you try PRRT upfront in lower grade nets, it will work. It's the same concept. They're both somatostatin receptor positive disease. The question is, do we need to, right? So we have to pace ourselves. So Lutathera currently is used second line or third line in lower grade nets, right? And that's how it was tested in the one study, took all the mid-gut or small bowel neuroendocrine tumor patients who have progressed through various lines of treatment. And what we were able to show that PRRT or Lutathera works really well. In the control arm, people who didn't get Lutathera, the median progression-free survival was somewhere around 8.5 months, as compared to almost 28, 29 months with patients who got Lutathera. So it's a day and night difference. So the drug is very good, works really well, and it's just 4 doses, great for quality of life. But is it really needed to be treated upfront, right? So it's a marathon. I think a lot of patients will get all of these drugs during the course of their disease. So we really have to tailor and sequence it well. So as of now, I don't think there is any urgency in the scientific community to study the need of doing upfront PRT right off the bat at the time of diagnosis, because you have to understand these radiopharmaceuticals. There is a lifetime maximum of how much you can get because of radiation based treatment, right? So you also don't want to use all your bullets at the time when you didn't need it, or at the time when there were some other really good relatively benign treatment options like sandostatin or lenalidomide. So that's why in the lower grade net setting, unless there is a clinical need, we tend to not use PRT up front. Having said that, there have been cases where we have used it up front because it was the need of the hour. The patient was very symptomatic, large amount of disease, bulky disease. We need to really put our best effective therapies up front. And in those specific circumstances, your doctors can make exceptions and they can start PRRT and somatostatin analog right up front. But for majority of cases, not really needed.
Got it. Thank you for your question. Next one from Brenda. Should abdominal adhesions be treated differently from normal protocols after abnormal CTs?
Great question. So should it be treated differently as compared to?
Let's see. Should be treated from normal protocols after an abnormal CT?
Well, abdominal adhesions diagnosis. And a patient who's had multiple surgeries, abdominal surgeries in past, and they present with a certain set of clinical symptoms, intermittent obstruction, pain. On CT scan, you will see that there is, distension in the proximal part of the bowel, and the distant part after the obstruction, it's empty. So there are these telltale signs. But is CT scan absolute, accurate in diagnosing addition? I've had mixed feelings about it, because sometimes additions are truly diagnosed when surgeons open somebody up and sees the actual scar tissues and the adhesions. And so sometimes some of our CT scans or imaging modalities are not able to accurately assess the degree of adhesions. It can go both ways. It can either over diagnose or underdiagnose. So I'll leave it at that. I think just don't rely purely on CT scans. I think you have to talk to your surgeon. If your clinical symptoms along with the CT scan or diagnostic imaging fits in, then certainly the surgeon needs to act on it, and they do exploratory laparoscopy and then kind of look for, okay, if there are adhesions, then they can try to take off the adhesions. Um, so it's not just as simple diagnosis based on just radiographic imaging. But if there was a scan that you would do, CT scans is usually the way to go forward in the abdominal settings, for adhesions. And of course, there are certain situations which will be very clear, like acute obstruction. So if there is an adhesion and is a very classic obstruction, then of course it'll be very clear on the CT. Majority of adhesions are more intermittent symptoms. Colicky pain kind of gets better and then kind of comes back up, and there's really no good reason to show because there are no major disease or we can't see tumors, and patient has had numerous surgeries in the past, so it is presumed that this could be probably adhesions. So it's not a straightforward diagnosis.
Understood. Thanks, Brenda. Next question from Lori. Hey, Lori. Some information first. PNET, KI 23%, grade 3, stage 4, completed PRRT in March of this year. Lesions also in stomach. These bled in June. And 5FX radiation therapy, which I think is 5 fraction radiation therapy, if I'm not mistaken, to control the bleed. Could the effectiveness of the PRRT have caused the bleed because of the lesion shrinking? Post PRRT scans have shown some shrinkage in the masses.
Absolutely. I agree. I think I've seen it both ways.
Okay.
The bleeding, especially after the treatment in this particular priority, in certain cases we give chemotherapies. If we see bleeding, it could be as a response to the treatment. Okay. Um, so certainly, especially the higher grade tumors like grade 3s, they tend to be more radiosensitive and they shrink more. So the response rate, if you see in the netter 2, much higher as compared to netter 1. That means a lot more patients show shrinkage in higher grade tumors as compared to the lower grade tumors, because they are more radiosensitive tumors. So when they shrink, these are vascular disease, vascular tumors, right? So they bleed out. So that can happen. That can potentially explain. Um, Sometimes, either way, I mean, if the bleeding is significant, you need to stop the bleeding regardless what's the cause. So this particular case, patient received some external beam radiation or radiation to stop and cauterize the bleeding. So that's that. I think that was the right approach. But you're right. I think if your scans are showing shrinkage, I would suggest that this bleeding could be as a response. So it's a good news rather than an ominous sign that tumors are growing and that's what's causing the bleeding.
Got it. Thanks,
One
Lori.
one thing I would like to mention,
Sure.
that certain neuroendocrine tumors, pancreatic neuroendocrine tumors, gastric neuroendocrine tumors can secrete a hormone called gastrin, and high level of gastrin can predispose you to get gastric ulcers, and sometimes those ulcers can bleed. I'm sure your doctors already looked into those aspects, and I'm sure during the endoscopy they didn't find any ulcerations. But if they did find this picture, this could be from hypergastrinemia or gastrin level. So that's just a side nuance to it. Might not be relevant to you, but for the other viewers.
Got it. Thank you, Lori. And I feel like this might be the first time I've seen your name. So if you're new here, welcome. If not, apologies and welcome back. From Susan, would proton radiation therapy be useful for a sacral bone tumor as opposed to traditional external beam photon therapy? And could you address why proton beam therapy is not more widely recommended for isolated bone tumors?
I have seen proton beam used. I My practice is advocate for the traditional external beam radiation, the ionizing radiation for bone mets. Very effective, works really well. And back in the days, we used to give several fractions. Now we know that sometimes 1, 2, or 3 fractions is more than enough to control pain related to bone mets. Um, since I moved to Miami, I do have luxury to also offer proton beam. One of the biggest reason why proton beam hasn't taken off, it's very expensive endeavor. Very few places have proton access to proton as compared to the conventional radiation, which is available in every small town, big cities. It's the standard way of doing radiation. So the just availability of proton limits its access. Proton is also not covered by many insurances, so there could be reimbursement or just the coverage related issues, right? So not every, then that limits the use of proton for a lot of different conditions. And is it really even needed? I mean, we don't have data to suggest that one works better than other for metastatic disease in bone in neuroendocrine tumor patients, right? So we don't have data. I think in my mind, both are relevant, reasonable techniques. But yes, to answer your questions, I have seen certain patients who received proton therapies. Could also be in the case maybe they maxed out on their conventional radiation. So again, I'll talk to I would recommend that you discuss with radiation oncology and see why they feel that one technique would be better. Is it a side effect that is related to conventional radiation, that the location in that particular patient that they're worried about for collateral damage to the normal tissue, or is that the reason why they are suggesting that proton will be better fit for them? In my opinion, conventional radiation works really well for palliative radiation for bone mets, and works like a charm to control pain for bone mets. So I don't see a major advantage in going to proton, um, despite the fact that we do proton here as well, so we have access to both.
Got it. Thanks, Susan, for your question. Next question from Sasheen. Sasheen, it says, if there were tracer infiltration during initial dotatate scan, can this have any significant impact on future studies or treatment decisions? The report only mentions that the infiltration somewhat limits evaluation on PET and likely decreases SUVs.
Yes, it would not have any implication for future scans. The radio tracer that they injected, be it gallium 68 or copper 64, whatever the radio tracer, it has a certain lifespan, right? So it is radioactive, it decays, it'll be out of your system in matter of days. So it will not really be relevant to the future set of scans. So please be reassured. Um, you know, it does impact the quality of that particular scan, because the amount of dye which was supposed to go into your bloodstream and then from your bloodstream to the tumors, that was sort of shortened based on how much extravasation happened, right? So it was taken away from your circulation and it went somewhere and got dumped into some of the skin or soft tissue, right? So that's all it means. Hopefully it wasn't significant enough that they couldn't see any tumors, so they're just trying to, on the cautious side, letting you know that the amount of dye was not delivered. So expect there could be some lowering of SUV theoretically. I don't even know if that's going to be true or not. But it will certainly not impact your future scannings. And just make sure when you go for future scannings, give a heads up to the technician. Hey, listen, last time there was dye extravasation, so they'll be very careful this time with placing the IV access, and make sure that this time they go for the right vein and minimize the chance of extravasation.
Got it. Thank you. And thanks for your question. Next question comes from our friend Shane. Hey, Shane, always great questions from Shane. Shane says, I saw new data release regarding DAXX mutations in PNETs and prolonged PFS following PRRT. The question is, should this play a role in sequencing of treatments?
No, no, not yet. We do understand that DAX is an interesting biomarker, and it's seen quite a bit, especially in well differentiated neuroendocrine tumors, and that too, especially pancreatic neuroendocrine tumors. Um, the data is not of such high caliber that it will preclude use of PRRT in certain patients if they don't have the DAX mutation, or if they do. As of now, I would not advise selection of patients or sequencing of PRT based on DAX expression or mutation. Um, where I think it will help us is moving forward as we refine our pathological classification. Sometimes these diagnoses can be tricky, especially when we are dealing with a mix of higher grade neuroendocrine tumors. So checking for these mutation and kind of giving us a solid diagnosis, that might help. But using DAX or other biomarkers to help sequence therapy, I don't think we are there yet.
Okay.
I do feel the because you take the example of netter 1 or netter 2, PRRT works really well across the spectrum. It might work better, a little bit better in some groups, and that we will try to figure out. But right now, I don't think I'm convinced yet that the DAX is, or for that matter, any other biomarker is ready for prime time to tell me these patients should get PRT next versus no, maybe third or fourth line. We're not there yet. The validated biomarker for PRRT use right now is somatostatin receptor expression. So if you have good uptake in the DOTA-8 PET scan, that means you have a lot of somatostatin receptors. You are a good candidate for PRRT, and you will do well. But it's very interesting that the scientific community is now studying biomarkers to help us tailor treatments. One of the tests is the NET test. They have a PPQ test where they are able to predict the ones who will benefit more from PRT versus less. And again, those are some of the tests where they also have data where they can predict responses to treatment, right? So I'm glad that the field is studying all of these, but we are not ready. I think it will be unfair to certain patients to really direct their treatment based on DAX mutation expression as of now.
Got it. Thank you. Another question from Shane, which is a great fundamental question. How do you describe to patients why stable is a good thing versus rushing to get rid of all of the cancer?
Um, Great question. So, you know, when I look for the response, there are two major categories for neuroendocrine tumors. One is either cancer is not responding, and what will the cancer cells do if they're not responding? They continue to grow, so they will look bigger, right? So it's either that category, and if they're not growing, something is making them not grow because their nature is to grow, maybe slower or faster growth, that's a different question. But if left alone, their nature is to continue to grow. So if our treatment's working, it's making them not grow. Cytostatic treatments, right? We do believe that sometimes when we see shrinkage or if it's gone, that's always a great idea, but to date there is no data to suggest if you choose shrinkage, those treatments have better median PFS versus those who don't show shrinkage, they don't. I'll give you an example. Netter 1, the the patients who showed shrinkage about 14 to 17%, the median PFS was around 29 months. The Netter 2, more aggressive disease, lot more patients show shrinkage, right? 30-40% response rates, but the median PFS was much smaller than Netter 1, right? So just showing the shrinkage is not the ultimate goal here, right? There are a lot more factors that go into the effectiveness of the treatment, and like grade of the tumor, the biology of the cancer, right? So to see whether tumors are shrinking and that correlates with the ultimate benefit to the treatment, I think it's premature. That's why we call these as surrogate biomarkers. They are not the final the main biomarker or the endpoint that is relevant to us is overall survival, right? Are patients living longer or not? Are they living with better quality of life or not? The tumor shrinkage, whether they're stable or they're shrinking a lot, as long as they're living longer, their cancer is stable longer, that's what really matters to us. Now, I personally like to see shrinkage, but the nature of neuroendocrine tumors, especially the well-differentiated low-grade type, is we don't see a lot of shrinkage, unlike some of our higher-grade cancers. That's just the nature of the disease. And a lot of our treatments, unfortunately, are cytostatic. And it's a good goal. So please don't be disheartened or then shrink. Stability, that's why we feel the stability is good, because that's part of the nature of the tumor. As compared to small cell lung cancer, we might be able to show a lot of shrinkage with chemotherapy, but the it's a much more aggressive cancer, and that effect of the treatment lasts few months, as compared to nets, where we might just achieve stability and not shrinkage, but that stability lasts for sometime years, right? So as long as the tumor is stable, that's good news. As long as they're not growing, as long as they are not spreading and causing end organ damage like liver failure and stuff, that's why stability is good enough for us. In select cases, yes, cytoreduction or debulking without causing too much harm is a what do you call icing on the cake, and we do that, and that's why we advocate for sometimes surgery, liver directed therapy, histotripsy, all sort of these things.
Got it. Folks, we just have a few minutes left. Today's episode has flown by. I want to try to get as many questions as we can. The next one from Katie. Should you continue on Cabometyx if it makes your liver levels, if it makes your liver levels are elevated and your tumor burden on your liver? It's a little, yeah. Did you follow that?
Yes,
Okay.
yes. So cabozantinib is the new entrant in our neuroendocrine tumor based on cabinet study. Great drug. The data looks really nice. And patients both with pancreatic nets and non-pancreatic nets, so it doesn't matter, lung, mid-gut, everybody benefits. So I definitely use a lot of cabozantinib. The issue with cabozantinib is it can be tough on certain side effects closely, but there is a good fix for it. It does come in different doses, 20, 40, and 60 milligrams. In my experience, very few people are able to tolerate the maximum or 60 milligram dose. Most of the patients end up being on 40, which is still very, very effective drug. So if you're experiencing liver function abnormalities, LFT is rising, it's possible that it could be from the drug. So you might want to consider dose optimization. Um, it could also be in some select scenarios. So if the lot of disease is in the liver and they're responding to cabozantinib and they're shrinking, so sometimes you can see a transient rise in liver enzyme because the tumor cells are dying and they're spilling all these liver enzymes. So you really need to make that distinction. But I have very low threshold to lower the dose for cabozantinib, because majority of patients are not able to tolerate the full dose, and we know that. And once we find the right dose which patient can tolerate, we stick to this. And then so this could be related to cabozantinib, and I want you to talk to your oncologist and decide what's the right dose for you, and if they can modify your dose a bit.
Got it. Thank you. Sarah Jane says, why does PRRT cause abdominal pain, and how common is that abdominal pain with PRRT?
Another great question. So many patients will not really complain of abdominal pain. And if you look into the drug package insert of Lutathera or PRRT, abdominal pain doesn't show up in the common side effects. But if a patient has a lot of disease in the belly, in the peritoneum, in the coverings around the small bowel, right? So what happens is when you get the drug, it goes through your blood and just lands and sits on the tumor wherever they are. So if you have a lot of disease in and around your small bowel, so it's going to go and attack the tumor there. And part of the dying process of the tumor is causing inflammation. So the tumor swells up. Okay. When the tumor swells up, it might cause some degree of obstruction or blockage, and that might cause pain. In certain cases, it can be so severe that people actually have bowel obstruction. So if you have a lot of disease in your belly, and you're getting PRT, certain centers, including ours, we are now giving a short course of steroids to prevent that inflammation. So it is part of that inflammation process. Fortunately, it is not a common phenomena, and it depends on if you are have a lot of disease burden in the abdominal cavity, and that's what's causing you. So if that's the case, then make sure talk to your oncologist about it. And a short trial of steroids sometimes helps with that. That's probably yeah. Otherwise, it's very well tolerated. In fact, one of the cool things about PRRT, what I like, is not only it slowed the cancer down, as I mentioned, the PFS data, but when they study the quality of life, people who got PRRT reported better quality of life. Most of our cancer drugs, they're able to fight off the cancer and stabilize, and patients live longer, but it comes at a cost of the quality of life. It's tough on the patients, like chemotherapies. So it was very heartwarming to see that our drug was not only stabilizing the cancer for longer, but also improved the quality of life. So that's sort of like hitting the bullseye for us.
Got it. Got it. Well, folks, that is our show today. There are a few questions we didn't get to, unfortunately, but I urge you to, again, reach out to lacnets.org/support line if you have follow-up questions, and we will be back in 2 weeks. We are switching back to the first and third Thursdays of the month in September. July 4th kind of offset that by a week, so we'll be back to our normal schedule. Robin says, the more I attend these luncheons, the more I learn. That is exactly what we're here to do, Robin. So thank you for sharing that. And thank you, Dr. Chauhan, for being on again and being so thorough in your answers and responses. We appreciate you very, very much.
Thank you so much, Rain, for the opportunity. Thank you, LACNets and CCF. And most importantly, thank you to all the listeners and viewers. Without your support, we would not be motivated to do what we like to do. And greetings from Miami. Wishing everybody well. Thank you.
Absolutely. I agree. Thanks to everybody at home. As always, I hope this program helped answer some of your questions. Thanks to our presenting sponsor, Ipsen Biopharmaceuticals. And finally, my name is Rain Bennett. I have been your host. Thank you for watching today, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone.